I'm John Strum, and this is Real Talk MS. It's February 18th, and we have a lot to talk about. More than 60% of the people living with MS live with pain, and the distraction and discomfort of MS-related pain can get in the way of fully engaging in virtually every aspect of your life. Joining me today to talk about managing MS pain is Dr. Bianca Weinstock-Guttman. Dr. Weinstock-Guttman is a neurologist and professor of neurology at the Jacobs School of Medicine and Biomedical Sciences at the University of Buffalo, where she's also the director of the Jacobs Multiple Sclerosis Center for Treatment and Research. But before we jump into today's episode, I want to respond to those of you living in the United States who've shared your concerns with me about how your healthcare may be affected under President Trump's administration. I've tried to respond to all of your emails, and at least some of you have wondered why I haven't talked about this. Well, if you're a regular listener, you know that I try to limit everything we talk about on this podcast to conversations that are evidence-based. I try to leave the speculation out because what's most important to me is that you know that this podcast is only going to share accurate, reliable information with you. It's why when we're talking about advances in MS research, I always include links to the underlying study so you can review the evidence for yourselves. Last week, the Senate confirmed Robert Kennedy Jr. as the Secretary of Health and Human Services. So talking about Secretary Kennedy any sooner would have been speculating on something that hadn't yet occurred. Now that it has, it's time to respond to some of your concerns. Now, I won't try to predict the future, but I will share some facts with you. As I'm sure most of you already know, Secretary Kennedy has a long history of being a vaccine skeptic, in spite of the fact that vaccines have been proven safe and have saved millions of lives. Take, for example, the polio vaccine. The polio vaccine is the single reason we no longer have polio wards in hospitals. Prior to the polio vaccine being developed in the mid-1950s, polio paralyzed about 15,000 people in the United States each year. In 1952, more than 3,000 people in the U.S. died of polio. The vaccine was developed in 1955, and the United States was declared polio-free in 1994. We can fast forward to 2022, when the city of New York reported the first case of polio in more than a decade. Or consider the COVID-19 vaccine. I know there are a lot of opinions about this vaccine, but the evidence of its safety and efficacy is unmistakably clear. I'll say that again. The evidence of its safety and efficacy is unmistakably clear. In fact, a research team at the University of Maryland School of Medicine compiled data on vaccinations and used a computer model of how COVID-19 was being transmitted across the United States. The team discovered that by the end of 2020, 80% of the U.S. population had received at least one dose of the COVID-19 vaccine. Their analysis showed that without this vaccination, we would have seen an additional 120 million COVID-19 infections, leading to 18 million hospitalizations and 3 million additional deaths in the United States alone. Other research shows that on a worldwide basis, the COVID-19 vaccine prevented more than 14 million additional deaths. During his confirmation hearing, when he was asked about the COVID-19 vaccine, Secretary Kennedy refused to confirm that this vaccine was safe or that it saved lives, claiming there isn't a system in place to monitor the safety of vaccines. This isn't true. The U.S. tracks vaccine safety through multiple monitoring systems. The CDC also checks how vaccines perform in other countries. During the COVID-19 pandemic, the CDC analyzed large patient databases from the UK and Israel, which added to the evidence that the COVID-19 vaccines were safe and were saving lives that otherwise would have been lost. In past statements, Secretary Kennedy has claimed that vaccines cause autism. He's claimed that vaccines cause cancer. And he's claimed that vaccines cause multiple sclerosis. None of these claims are accurate, and none of these claims are supported by accepted science. Actually, there's ample scientific evidence that refutes each one of these claims. To his credit, during his confirmation hearing, Secretary Kennedy said that he supports vaccinations and will follow the science in overseeing the Department of Health and Human Services. I try to remain hopeful that Secretary Kennedy believes his own statement, but we're already seeing that there may be less science to follow, as the NIH, the largest funder of MS research in the world, has enacted a new policy that will result in billions of dollars in cuts to NIH research grants. Science shouldn't be political. That's why Congress has long provided bipartisan support and funded the life-saving research supported by the NIH, research that's conducted in every state across this country. So I hope each of you will take a moment to contact your representatives in Congress and let them know that any cuts to NIH funding means we lose momentum in developing new treatments for MS, and we have even less access to clinical trials. We can't let anyone put progress on hold. Last Friday, 1,300 people at the CDC were fired. I'm hopeful that everyone living in the United States with any diagnosed chronic illness will urge Congress to pass legislation that restates and resets the priorities and the already congressionally approved funding for the National Institutes of Health, the FDA, and the CDC, so that these vital organizations continue to fulfill their responsibility to the American people. Please don't underestimate the power of your voice. Make sure your elected officials hear from you and clearly understand the priorities of the people that actually elected them to office. With more than 20 disease-modifying therapies carrying widely varying risk profiles, the MS treatment landscape has become more complex. So to help general practitioners and neurologists provide the best care to their patients, MS experts in Australia and New Zealand have published consensus guidelines for treating adults with MS in those countries. As you might expect, the first part of the guidelines focuses on disease-modifying therapy. Because some DMTs are quite powerful but carry a significant safety risk, while other DMTs are less potent but are generally safer, the new guidelines stress the importance of having discussions about risks, benefits, and expectations with each patient. I'd also comment that those same discussions should be happening in every neurology office, everywhere. These guidelines recommend starting a disease-modifying therapy as soon as possible for people diagnosed with relapsing remitting MS, and the guidelines recommend the newer, high-efficacy DMTs if they align with the patient's risk tolerance. The new guidelines also offer advice on when it might be time to switch to a different disease-modifying therapy. They stress the importance of limiting infection due to a compromised immune system by ensuring each patient has received all of their recommended vaccinations. And the guidelines cover DMT use during pregnancy, stressing the importance of an individual approach based upon each patient's overall status and the specific DMT that they're on. If you'd like to review the new guidelines for MS care in Australia and New Zealand, you'll find that link in today's show notes. The sooner an individual is diagnosed with MS, the sooner that individual can receive care, the sooner they can start a disease-modifying therapy, and the better the outcome is going to be. The key to early diagnosis and treatment is having access to quality MS care. If you're living in or near an urban area, that access is at least geographically available. But if you live in a rural area, that access is far from a sure thing. The National MS Society, in collaboration with Deloitte Consulting, published a study identifying so-called neurologist and MS specialist deserts throughout the United States. These are rural areas where there is no MS specialist and where a neurologist's office may be a few hundred miles away. As a result of the insights gained through this study, the National MS Society has launched an initiative aimed at expanding access to treatment, care, and support for people living with MS in medically underserved rural communities. Initially, this program will be rolled out in Alabama, Arkansas, and Mississippi. In connecting with community leaders and healthcare professionals in these 3 states, the MS Society has begun to identify barriers to local MS care relating to transportation, workforce shortages, and the absence of broadband and internet connections that could otherwise facilitate telehealth visits. The MS Society is connecting with local community health workers, educating them about multiple sclerosis, and connecting them with resources available through the Society, like the MS Navigator online referral form. Using this referral form, healthcare professionals can directly refer patients to MS navigators who are trained to provide newly diagnosed patients with information about MS, symptom management strategies, financial planning, information about health benefits, assistance with employment issues, and they can even connect those newly diagnosed patients with other people who are living with MS. As part of this initiative, the MS Society has partnered with the National Rural Health Association to raise awareness about MS and equip rural healthcare professionals who aren't neurologists with the knowledge and tools that will allow them to deliver high-quality care to their patients living with MS. A key aspect of the MS Society's partnership with the National Rural Health Association is developing educational opportunities for rural healthcare professionals and connecting them to society resources. The MS Society recently hosted a National Rural Health Association educational series designed to address the specific challenges MS poses in rural areas, titled How to Know Multiple Sclerosis When You See It, Identifying Early Signs and Symptoms for Rural Healthcare Professionals. This initiative will enable primary care physicians serving these communities to become better acquainted with spotting signs and symptoms that could help them diagnose a patient with MS, or perhaps refer that patient to a specialist outside of their local area who's qualified to make that diagnosis. Early diagnosis, early treatment, better patient outcomes. This initiative seems to check all the boxes. Evidence shows that obesity is associated with faster MS disease progression. Evidence also shows that smoking is associated with faster MS disease progression. Now, study results from a research team at the Karolinska Institute in Sweden show that obesity and smoking together lead to physical worsening and cognitive decline at a faster rate than either would on their own. The study analyzed data from more than 3,300 MS patients followed through the Swedish MS registry. Other research has shown that obesity and smoking together lead to disease worsening in diabetes and heart disease. Now it appears to be true in multiple sclerosis as well. Diving deeper, the researchers were able to determine that it's obesity that worsens the impact of smoking. Well, it goes without saying that if you're living with MS, you can only help yourself by not smoking. And now, you may have one more good reason to stop. If you'd like to review the details of this study, you'll find a link in today's show notes. Pain is a common MS symptom that can be challenging to manage. My guest, Dr. Bianca Weinstock-Guttman, joins me in a moment with treatment strategies designed to help manage MS-related pain. Pain is a common symptom of MS, affecting more than 60% of the people who live with MS. The distraction and discomfort of MS pain can get in the way of fully engaging in, virtually every aspect of your life. Joining me today to talk about managing MS pain is Dr. Bianca Weinstock-Guttman. Dr. Weinstock-Guttman is a neurologist and professor of neurology at the Jacobs School of Medicine and Biomedical Sciences at the University of Buffalo. Dr. Weinstock-Guttman is also the director of the Jacobs Multiple Sclerosis Center for Treatment and Research at the University of Buffalo. Welcome to the podcast, Dr. Weinstock-Guttman.
Thank you very much for inviting me.
I always like to start these conversations by getting our definitions out of the way. Can you explain the difference between neuropathic and musculoskeletal pain?
Yeah. So the neuropathic pain in MS are related to the direct injury from MS disease itself. And it's affecting primarily what we're calling the spinothalamic or the sensory pathways, starting from the spinal cord, going up to the hub, to the thalamus, and up to the parietal area. The musculoskeletal pain are usually related to the muscle tightness, to the joints. They are also related in the end to a disability from MS, but it's related to their abnormal gait, abnormal positioning. So they are different. They're often, though, together. And that is becoming much complex in how to treat them.
How might someone living with MS experience these two types of pain?
So the neuropathic pain are usually as kind of a neurologic pain. They're usually affecting severely, often acutely, the face. That is the well-known trigeminal neuralgia. There are other also pain, so it's only in the face, burning sensations. There are other ones that we know about, the Laramide phenomena, the electrical sensation going down your spine when you're bending forward your neck. And there are also the one that we're calling this painful tonic spasm. They're coming up actually associated with spasm on your arms. They're very painful. The other musculoskeletal pain are usually presenting more as a tightness, feeling burning, less burning, but more deep pain sensation in the legs mostly. That are usually, or back pain from often associated neurodegenerative problems.
What's the difference between acute pain and chronic pain?
So it's general in medicine, we like to have this definition on acute, something that's coming up suddenly, lasting up to 1 month from the injury to the recovery. And anything that's over 3 months, we're calling chronic. That is also using on all the other medical diagnoses and diseases. So acute pain usually starts and usually seen on the neuropathic pain, as you said, it's the trigeminal neuralgia, often one of these acute pains. And within, 1 month, it goes away, usually with treatment. Chronic pains can be also neuropathic, could be also musculoskeletal, and is lasting more than 3 months. Often it's starting to become evident from a pathological standpoint, by extending of the area affected. It's more in the beginning when we have the injury directly on a more localized area, but with the time, the nervous system trying to fix it, and the fixing is actually abnormal and extending, affecting different sensory area that produce the chronic pain.
My wife lived with MS and she experienced occasional neuropathic pain. It wasn't constant, so it was not 3 months straight, but it was always in the same place on her body, and she experienced the same pain sensation, and it proceeded over many, many, many months. How does someone know whether they're experiencing acute or chronic pain?
It's, it's very, very important to define actually when it starts, how it's lasting, and also, as you said, positioning, if it's changing the position that's maybe much more related to musculoskeletal versus the neuropathic. But the concern is then if it's becoming and reoccurring, if it's not very severe, then and doesn't need the treatment, it's keep going. But the problem is it's becoming more frequent and more severe and more lasting longer. Then we have to really go into understanding what is the reason for this pain and try to provide the more specific intervention.
Let's talk a bit about treatment options. Are there treatment options available for acute pain?
Sure. So if we're thinking about the acute pain, the best is already mentioned, the trigeminal neuralgia, is the anti-seizure medication before anti-epilepsy medication. So it's lower severity of is the gabapentin or pregabalin. But most benefit that I saw is more from oxcarbazepine. That is the most effective in treatment of this acute, most severe pain. Antidepressant medication are also very good in a lower dosage, nortriptyline, amitriptyline, duloxetine, or venlafaxine. They're also good for pain that are lasting longer on the chronic pain. The other medication for intervention for the musculoskeletal pain, when you see more the spasticity, we'll think about muscle relaxants, it's baclofen, tizanidine. Baclofen is actually a good benefit medication for spasticity too, but is also for pain. The other, joint pain and so on, you should try the NSAID. I'm not very much for opioid. The cannabis are good for spasticity. For general pain without spasticity, it's only 50-50, doesn't have so much benefit. Physical therapy, other interventions as kind of the mindfulness, the CBT, the cognitive behavioral therapy, and anything that you can put your mind to help your pain are very helpful in addition to the pharmacological interventions.
And is there a different treatment path, a different set of interventions for managing chronic pain?
So chronic pain, as I said, is usually more difficult to control. But they require, as I said, if the chronic pain are neuropathic, if you feel, we should go again with medication as nortriptyline, amitriptyline, and eventually, if it's more concerning for using also, as I said, cannabis, I'm not going for the opioid. But for chronic pain especially, we need to absolutely add on physical therapy, relaxation, cognitive behavior therapy, and mindfulness. So we have to get the patient involved on different way to use their own mental and interaction to try to decrease the pain.
As you were just discussing chronic pain management, I heard several mental health treatments like antidepressants, mindfulness, cognitive behavioral therapy. Is there a connection between pain and mental health?
So, as we have patients with depression developing pain or developing depression after long chronic pain, it may be different. But interestingly enough, many of the medication for depression clearly have benefit of pain. And the last one, as we know, is duloxetine, the Cymbalta, that was primarily given for depression and identified that have benefit for pain. That was a secondary outcome, and that's what the same thing with gabapentin. That was an anti-seizure medication found at Afaten that has benefit on pain. So the relation between depression that we really do not know what is the reason and all the chemical imbalance. We do know that medication that benefit depression may benefit the pain. And there are certain medications that are much better on pain, as the tricyclic or as amitriptyline, nortriptyline, or other as duloxetine, or as mentioned before, Effexor, venlafaxine is better. SSRIs are not so good for pain. So there are certain medications that are beneficial also for depression and also for pain, and they will be very helpful to be sure that we're using this, decreasing the number of medication that we're using for different diseases. And also we know that patients with depression may have a lower threshold and may have much more prone to develop pain and chronic pain, unfortunately.
So it sounds like somebody who may already be getting treated for depression, say with an SSRI, if they develop pain symptoms, perhaps changing that medication could serve both kinds of symptoms that they're facing.
Absolutely, yes. Meaning that is very important, and we have to know and to follow with the psychiatrists and so on how to change the medication, not to stop immediately, change going down in one, increasing the other one, not to overcome because we cannot add on because may have more side effects. But yes, should try to consider medication that have effectiveness also on depression and also on pain.
I think you've already started answering this question, but I'm curious if, in addition to medication, are there any alternative management strategies for managing pain?
Yes, absolutely. So as already mentioned before, there are, besides exercise, physical therapy, there are ways how to involve the patient mentally to try to control their symptoms, including the pain. And that is cognitive behavioral therapy, biofeedback, mindfulness, or acupuncture. I believe acupuncture can be helpful also in pain, massage therapies. All of them can be helpful and may decrease the use of pharmacological interventions. Yes.
In MS, pain and itching seem to go hand in hand, but it's not physical itching in the traditional sense. Can you explain how itching might feel to someone who lives with MS and how it might be treated?
So itching from MS and itching on any kind of other neurological or neuropathic diseases are different. We call it neuro-itching. Neuro-itching is using actually the same pathways as the pain, but they have different really causes for different inflammatory markers and different receptors. And sure enough, different treatments. And as mentioned, I had some patients that are really severe itching. The only benefit I saw by using the anti-seizure medication, the oxcarbazepine. They also having information that the opioids that may be used in chronic pain is actually worsening the itching. So clearly not to use opioids if any kind of neuro itching. Also, there are creams. There are creams sometimes that may, prevent to use different medication with all the side effects. Creams that have inside or capsaicin, but also may have amitriptyline, nortriptyline, gabapentin, ketamines. There are including on these creams. They are doing in compound pharmacies. They're very expensive, no insurance supported, but they are helpful to, rub it around exactly where the pain is coming up.
As we're talking about medications, is there any risk of addiction to MS pain management medication?
Yeah, addiction clearly can come up. Actually, even a long-term medication, they're not, they're associated with side effects. But opioids in cannabis are the primary concerns for addiction. And especially if we have family members, people with depression, or even young people, they are much more prone to become addicted. So it's very important to keep this in mind and try to prevent, as I said, using opioids, even cannabis, and especially, as I said, in young people and in people with depression and family history of addiction.
You mentioned family history. I'm wondering, how should someone with a family history of addiction approach their MS pain management?
First of all, they know and they have to update the provider not to consider opioid. And that's the most important. And many of people are very afraid by, and they have to come openly and indicating whatever the medication will be used. Besides, as I said, the other, what you brought up, the cognitive therapies and so on, but trying to decrease the amount and not to use cannabis or opioids.
Well, Dr. Bianca Weinstock-Guttman, I want to thank you for all you do to improve the lives of people who are living with MS. And thanks so much for talking with me today.
Thank you for inviting me.
That's going to wrap up this episode of Real Talk MS. Real Talk MS is powered by the National MS Society. And you can share this episode of the podcast by letting your friends or family members know that all they have to do is point their web browser at realtalkms.com/390. You'll find that link in today's show notes so you can easily copy and paste it right into an email or a text. And if you have a minute, I hope you'll visit the Apple App Store or the Google Play Store and download the free Real Talk MS app for your iOS or Android smartphone or tablet. It's the best way for us to stay connected. The app will automatically download the latest episode of Real Talk MS. You'll be able to access any of our past episodes. You'll be able to save your favorite episodes. And it's a great way for me to share bonus content with you. The app is free, so I hope you'll download it today. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.